Our next topic is an evolving topic that I suspect is starting to get more and more conversation in your organization. It's a topic that you can hardly pick up a news release, either your newspaper or online or however you get your news today, without hearing something about the opioid crisis and what it's doing to our society and what are the contributing factors and how it's being played out. Obviously, as healthcare providers and institutions, we certainly have a role to play in that. Again, the governor has made this a task force initiative in our state. The Attorney General has also serving as the chair of the governor's task force on that. There has been a group convened and much discussion regarding what should be unfolding in our state. And recently, even as a hospital association, we have convened a task force that held its first meeting last month, chaired by Suzanne Woods from our hospital association. Many of you were on that first meeting we had last week, I believe it was. Today, we want to elevate that discussion a little bit and let you hear what is going on in one of our member organizations, and also have some updates from Blue Cross, who is doing some work. And we've been engaging with Blue Cross for quite some time now, number of months, in regards to how the future of that might look. Before I introduce our speakers and the topic, though, let me just remind you, if you're the quality contact we have at the association, there were 3 initiatives that we agreed to work with Blue Cross on this year, and one of those has to do with opioids. So I encourage you to look at those 3 pledges, commitment forms that we've asked for hospitals to commit to. One of them is in this area, and encourage you, if you have not signed that, to have that signed on behalf of your organization. What it really says is that you will create a point person on this topic. You will elevate this conversation in your organization, and you will make it a priority of your work going forward. Beyond that, there's not much more to the pledge other than just saying it's such an important topic. We need to move the needle on that this year as an industry in Alabama. So I encourage you to look at that if you've not addressed it already in moving it forward this year. Okay, our next topic, combating opioid misuse. We have Krista Bright, who is a PharmD, Dr. Darrell Weaver, Sherry Stroud, and Eleanor Odom, who will be a part of this group presentation. And in just a minute, I'll invite all 4 of them to the podium here. We've got some chairs, and we'll get this underway. Blue Cross is using information to provide to physicians to support appropriate prescribing practices. And I think one of the things that we've all understood is that as a facility, prescribing practices initiate with physician orders. And we also recognize the important element, if we're going to address this topic, it has to be inclusive of physicians, and it has to work with physicians in that regard. So we'll hear about that program that Blue Cross is initiating, and I think it's something to listen carefully to and ask ourselves, how can we embrace that and how can we add to that in making our move in our state? Secondly, we're also going to hear from the quality staff at Spring Hill Medical Center. Spring Hill and Mobile has been doing some innovative thoughts on this topic and have some initial work we'd like for them to share with you, again, as a springboard of best practices for the rest of us to perhaps be able to build. They've been working with their physicians and other staff to improve their utilization or diminish their utilization in a number of departments of their organization. At this time, I'd like to introduce our speakers, and when I finish introducing them, we'll ask them to all come forward. First is Dr. Darrell Weaver, who began starting the Blue Cross Blue Shield portion of the program. He will share some of that information with us. He'll speak about 5 minutes, and then we'll leave our panelists time to complete the time, and then we'll have questions at the end. Dr. Krista Bright is a clinical pharmacy specialist with Axial Healthcare, who is working with Blue Cross. She studied chemistry at Tennessee State University in Nashville, and then received her PharmD from Midwestern University in Glendale, Arizona. Dr. Bright has practiced in several niche areas of pharmacy with a focus on pain management, palliative care, and hospice for more than 8 years. She has also lectured to pharmacy students on vulnerable and underserved populations. Next is Sherry Stroud. She's the Director of Quality and Risk Management, and Eleanor Odom, who is the coordinator, and both are employed at Spring Hill Medical Center in Mobile. Sherry began working at Spring Hill in 1994 as a nurse. During her tenure, she served as a charge nurse, a clinical educator, and a special projects coordinator before moving into her current role. She has a master's degree in nursing from the University of Mobile. Eleanor Odom joined Spring Hill a few years after Sherry. She, too, has served as a charge nurse and clinical educator as well as a case manager. Prior to this, she worked at USA Medical Center at the Mobile Health Department. Eleanor has a master's degree from Spring Hill College. Also here with us, as I mentioned before, Dr. Darrell Weaver. Dr. Weaver serves as the Chief Medical Officer at Blue Cross Blue Shield and is the Vice President of Network Solutions. Dr. Weaver is a graduate of the University of Alabama Medical School and an emergency physician who practices at Bibb Medical Center for a number of years. He's going to introduce the Blue Cross portion of the program and provide a few important updates from Blue Cross. So Dr. Weaver and the rest of your group, if y'all would all come forward, we'll ask you to please sit at the podium. Dr. Weaver, take the podium. Come on up.
It's great to see so many familiar faces out there. If you know me, raise your hand. See? That's fair. Hey, so as Keith just said, I have 5 minutes to speak. Rosemary was pretty strong on that 5 minutes. She got him to announce it out loud, so I have 5 minutes. Okay, so I'll start quickly. So I'm going to tell you about some of the things that we're doing in the opioid space. I like to say that because of Blue Cross's size and presence in this state, we not only have the ability to affect responsible prescribing, we probably also have the responsibility to as well. So you're going to hear some of the things that we're doing now to affect that. To start with, 3 days ago, April the 1st, we've come out with some changes in prescribing. First of all, Narcan, which is the antidote for opiates, is going to be covered by Blue Cross. There are 3 forms of prescriptive Narcan. One is a pre-filled syringe, the second is a nasal spray, and the third is an auto-injector, sort of like an EpiPen. That one's not going to be covered. That one's $4,000, okay? Not going to pay for that when the others are $60 and $120. Now, those drugs also are name brand, but to help people get those that need it, they can get those drugs covered at a generic copay. So that will help that. Also, there's going to be a 7-day limit on how many pain pills you get for immediate pain pills. So if you get a prescription for an immediate release opiate, such as Lortab, Norco, oxycodone, things like that, if you haven't been on opiates within 120 days, then you will only be allowed, we will only cover 7 days with to start. So let's describe how that works. So let's say you have a surgery. Orthopedic surgeons they're likely to give you a prescription for 60, 70, 80 pills when you go home from the hospital. So we've defined and we've looked at, for instance, a Norco, those typically could be written as 1 to 2 Q6 hours, which means you could have as many as 8 a day. So we have predefined 7-day prescription is 8 times 7, so do the math, that's how many you're going to get covered. Now, it's not going to really affect the patient that much because copay will be adjusted accordingly. So if you end up walking out with 40 pills and the prescription was for 80 pills, you only have to pay half the copay. At the end of that 7-day period, if you're still in pain, you can go back to the pharmacy and get the rest of those pills for the rest of the copay. It does not require anything on the physician, doesn't require extra money over than just completing that copay. So that we hope will work very well. A number of states in the country are doing this. North Carolina started at the same time. Some other states have mandated this. We're also implementing a prior authorization program for extended release opiates. So things like OxyContin, those are the ones that if you have chronic pain, you're going to be on it for a long time, then those are indicated. We're trying to reduce the number of people who get prescriptions for extended release opiates, but they're getting it for acute pain. That's not appropriate. So a physician would have to go through a prior certification program for that. So now we'll get into Axial. Axial Healthcare is a company. They're based in Nashville. They work for quite a few health insurance across the country, a lot of Blues. And here's the way they work. So any physicians in the audience still? So when you got out of med school, finished residency, and went into practice, you talked about a lot of things at the hospital. When you talked to other doctors, you talked about, do you admit people for this? What kind of antibiotic do you write for that problem? So you go on and on. You sort of figure out how people do things. But one thing that we didn't talk about was opiates. We didn't say, hey, how many pain pills do you write for somebody when they come into this? Do you write refills for that or not? So because that was not a very frequently discussed subject, The way that each physician writes a prescription is sort of their own way. That's just, they've developed that pattern over the years. And you don't really know how you stand compared to other ones. So when you write those, my way of writing them in the emergency room was I would just write 15 pills. That to me was 4 days worth of medicine. If they still needed pills after that time, then they needed to see somebody else. I didn't know if the doctor working next to me gave 20 or 30 or 50. Other doctors in practices, I didn't know how they prescribed. So one of the ways Axial works is they take our claims data and they look at all claims data and they present that back to physicians in a way that describes to that physician how they prescribe. So for instance, a physician could come up with an opiate score and they get presented and said, your score is 52. And 52 is a percentile, which means your score is better than 52% of the doctors in the state of Alabama. And then other doctors there's 48% who are worse than you. Your score could be 90, your score could be 10. Physicians I like to believe by and large, they're good people, they're not out to do bad things. Most physicians, when presented with data, will change behavior. So if you're shown that what you consider a normal way of practicing happens to be at the 5th percentile and 95% of other doctors don't write medicine that way, you're probably going to change your habits. So this is one of the main ways that Axial will work for us, is presenting data to the doctors. It also presents us some data. There's about a top 1%, or actually the bottom 1%, people who come in that 0 to 1% range. There's some dangerous physicians out there. It helps identify those to us. So we can take action on that as well. But once again, I like to present this as, this is, for the other 99%, it's not punitive, it's just informational. It will help them understand how they're prescribing. It will help them understand which of their patients are doctor shopping and going to other doctors, which of their patients are on dangerous combinations such as benzodiazepines. And I believe when presented with that data, they will act upon that. So with that, I'll let Krista come up and give the read details of the program.
No, that's okay. Okay. Thank you. Okay. Perfect. Yep. All right. I'll try to stay here. Good morning. Thank you all for being here this morning. My name is Krista Bright. As Dr. Weaver said, he always gives us a great introduction, so I will be mindful of our time. Axial Healthcare is a data analytic healthcare team. Fancy words. All that means is we have a great group of people, data scientists, we have pharmacists, we have physicians, as well as an advisory board, engineers that all come together to take in the information as far as the medical claims, as well as the pharmacy claims that are provided to us by Blue Cross Blue Shield of Alabama, and put it into this awesome algorithm that's able to quantify and compare providers to providers within their peer group. I think what's unique about Axial is the fact that we actually partner with health plans. And so through that, starting with the health plan, we are able to provide them data on the back end in regards to their providers. We also reach out to the providers telephonically. So there is a team of pharmacists as well as engagement specialists that we actually telephonically reach out to the providers that show up in our list, if you will, and I'll kind of talk to you about that. And then, of course, the end game is to affect the end user of the medications, the patients. So we have a platform that we call Axial Practice. And so Axial Practice is the part of the online portal that is actually visible to the providers. And so when we call out to the practitioners in the field or in their office, we want you all to be able to log on to this Axial Practice site and view the information that we have for you. So providers will not show up in our data or in the data that's provided by Blue Cross Blue Shield unless they have written 6 or more unique prescriptions, so for 6 different patients, for opioids within a 90-day time period. So not all providers will even populate in the data that we receive. We have the practice portal that's utilized by the practitioners. We come up with a RIM score, risk identification and mitigation score, and this is just a way to quantify where you stand within your peer group. We also have a RISE, or risk-informed surgical evaluation tool, that is utilized by practitioners in order to see how risky is it for this patient to have a surgery at this point. And so it's based off of your opioid utilization for that patient. It's based off of whether or not that patient has, they smoke or things like that. So we're able to just put all this information into an algorithm and come up with the score. The higher the score, the riskier it is for that patient for poor outcomes to have surgery at this time. And so it's really a way for the practitioner to see if there's a care plan that they can work through before surgical intervention for that patient. And then lastly, Consult, which again is the outreach from the pharmacists and the engagement specialists here at Axial. This is what Axial Practice looks like. And so we have all these colors and these fancy hexagon, and basically red through green, and it means exactly what you think. I like to say green is awesome, you're doing a great job. Red, just room for improvement. And so what we like to focus on are those practitioners that fall into each one of these categories. So we call practitioners that fall into the red, we call practitioners that fall into the green. The whole purpose is for providers to realize that we are a resource, and someone, if they have questions, concerns about a patient in regards to their opioid utilization, that we're certainly there to help them and walk them through and talk them through and answer any questions that they may have in regards to their patient's care in regards to opioids. So, and these all are Jane Doe, John Doe type patients, even though they have interesting names. So this is what the portal will actually look like. Blue Cross Blue Shield has done an excellent job, and you'll see a little bit later, they've done an excellent job in giving easy access to the information. We're not trying to make this an extra step, something more you have to do, another password you have to remember, another username that you have to remember. So in order to gain access to the Axial Practice portal, you would log in, as you already do, to the Blue Cross Blue Shield website, and there's 2 clicks after that. So it's very easy to get to, and I'll show you that in a second. In regards to, I'll go back one step. In regards to the 45, or the RIM score, if you will, there are 15 metrics that go into coming up with that number. So the morphine equivalent daily dosing, and this is all based off of the provider or the practitioner. So your average morphine equivalent daily dosing, whether or not your patient has concurrent utilization of a sedative or caresperdal or something like that, whether or not your patient has received multiple prescriptions from multiple prescribers. That also factors into this number, as well as whether or not that patient has had a urine drug screen, which of course is recommended, a yearly drug screen by the CDC. And so all these things, there's 15 factors that go into creating and calculating this score. And what I like to focus on, when you log on, you will see these 5 numbers here, and they're all hyperlinks. And so you can click on each link, and if there's a number there that correlates with your patient, and if you click on that, you'll actually be able to see the patients that fall within those patient alerts. The first number, which is a 0, is actually opioids prescribed for patients who in their history have a ICD-10 code, soon to be ICD-11, it sounds like, of substance use disorder. And so that's important. You would, as a provider, a practitioner, you would want to know if you've prescribed an opioid for a patient that has a history or a diagnosis of substance use disorder. So that's something that comes into this algorithm based off of the medical claims data that we receive from Blue Cross. As well as the second number, the number 3, is the concurrent utilization of sedatives. Again, we're not pointing this out to say, stop it. Why are you doing that? It's, are you aware? Because some of these prescriptions that are written, certainly the concurrent utilization of sedatives, a lot of times that prescription is written by another provider, not necessarily by you. And so we just want to make the providers aware that their patients are on these other medications. The third one is just to make you aware that a patient that you prescribed an opioid for also has a sleep apnea diagnosis. Again, just being aware that that patient already has decreased respiration, and do you want to further decrease that patient's respiration with placing them on an opioid. The number 5, the one that's highlighted, that's a multi-prescriber. So I spend a lot of time on this one. We hear a lot about the PDMP, which is a great tool. Again, this is just an added resource to your current resources that you already have in place. But what we like to see is that you're clicking on these particular patient alerts, reviewing the patients that are falling under this, and aware that your patient has received an opioid from another provider. Within that, we get all the time, because of course you have offices that have multiple providers within an office, and we understand that. So within this particular patient alert where you see the number 5, if a patient receives an opioid prescription from you, and then they receive an opioid prescription from another provider within your practice, that does not count against you. It has to be 4 or more providers in the same practice. So that patient has to receive a lot of prescriptions from multiple providers in that practice in order for that to show up here. Now, if they receive a opioid prescription from yourself and then a provider outside of your practice, that will show up here. And then the last patient alert here is the patients that have been prescribed a long-acting and a short-acting opioid. And again, this is just for awareness. We know those chronic pain patients, certainly a lot of them will be on a long-acting and a short-acting opioid. So again, just to be made aware. Oh, 5 minutes. Oh, okay. Been talking a lot. Oh my goodness. Okay. So when you go back, when you actually click on the patient names that are highlighted, it will take you to the care pathways that are specific to that patient and to those alerts. So you can also access the care pathways without clicking on the particular patient, but that's an easy way to get to the care pathways specific to that patient. The care pathways are evidence-based. They've already been vetted and created, already documented for you. They are easily printable as well. So if that's just information you want to have at your office, feel free to print those out and have that information available for your staff. Again, that's what the care pathway looks like. All this information is available on the online website, the online portal via the Blue Cross Blue Shield of Alabama website. Here you'll just see this is RISE. So when I was speaking of being able to determine whether or not your patient has a high risk for poor outcomes after surgery. So this RISE tool is looking at behavioral health, so whether or not a patient smokes, opioid utilization, and care coordination. So all that going into the algorithm to determine whether or not that patient is at high risk. The higher the number, again here, the poor outcomes, likely of poor outcomes. With the RIM score, I apologize, I did not mention, the higher the score with the RIM score, the better. So they're opposite. Higher the score on the RIM with the, I want to go here so you see that. The higher the score here, the better. The higher the score here, oops, poor outcomes. Again, this is just a tab within the online portal. You'll see additional resources. There's opioid contracts here. There's information in regards to the treatment of opioid and patients in pain. So there's a lot of information that's already been evidence-based and available to you that you can select and print out for your practice. Again, I won't go through this again. This is just the view of the portal. This is what it looks like when you automatically log on. You'll see at the top right, I know it's very small, but you can also download. So if your provider or practitioner doesn't have the time to get on the portal, even though we want you on the portal because that's where you can click the hyperlinks, you can also download and print it out. And on the first page will look like this, and the second page will show the 15 factors that go into coming up with that RIM or risk identification mitigation score. This is the document that shows you actually how to log on to and actually access the portal. So again, you log on to Blue Cross Blue Shield the way you always do. You will go to, I think it's profiles and reports kind of in the middle, and then you'll click opioid pain management tool, and that's it. And you're there. Again, we're just trying to be an extra resource. So if we're calling, some pharmacist is on the phone from Axial Healthcare, if we could just get someone to engage, we're really just trying to see where you are, to see if we can assist in any way, form, or shape, make you aware of information. If you're not aware, we'll usually walk the individual through, office manager, quality manager, walk them through the portal so we can just show you how easy it is to access, and then certainly answer any questions. This information is updated on a monthly basis, so this is not something that we're asking for you to log onto on a daily basis, but it's updated monthly, and again, you can print these reports as well. And this just walks you through how to access. These are the care pathways. They, again, are little symbols, kind of the hexagon, and you can select different types of pain and see what's the evidence-based module of how to go through and treat that type of pain. Again, a lot of this is for our primary care providers, but certainly able to be utilized by any practitioner. These are the key performance indicators that are reported out to Blue Cross Blue Shield on a quarterly basis. Again, with the other health plans that we have worked with, we have seen a decrease in morphine equivalent daily dosing, a decrease in the actual poly drug and multi-prescriber. So that's something we're touting ourselves. We're very proud that we're able to kind of make that difference with patient care. So our main goal is just to increase patient care as it pertains to opioids. Sorry. And I'm sure we'll get questions at the end, so thank you very much.
Good morning. I'm Sherry Stroud. I'm the one that cringed when Keith said 1994. I was like, oh my gosh, that seems so long ago. I've been at Spring Hill and in nursing for 24 years, and I love it as much today as I did when I graduated from Troy in March of 1994. One of our passions is our Narcan rescues and our opioid use in the hospitals. So when Margaret and Rosemary asked us to talk, we jumped on the opportunity because Eleanor and I have been working on this for a couple of years now, and we would love to share with y'all what we've done. Does anybody have these patients? Absolutely, right? Everybody raise your hand. And don't you want to look at him just like The Rock does? What's that, his smoldering stare? We're going to share with you some warning limits that we put on our opioid dosage, some monitoring that we put in place our post-operative monitoring, and how we're evaluating our Narcan rescues to change practices with our physicians. I love what he said about show them the data and they will change practice. We tried to form a physician committee, and we had a group of physicians come, and it got bigger and bigger and bigger with different recommendations. So we decided instead to collect the data, show them, and get them to change the practices one-on-one. It was a lot easier than having an orthopedist, a surgeon, an anesthesiologist, and a hospitalist all in the same room. The first thing that we did is we got our PharmD involved and kind of decided what do we want to set our limits at with Dilaudid, morphine, and Demerol. So we took this through our physician committees and with approval, starting with our PharmD, and we sent this out to all of our physicians that practice at the hospital. Then we worked with our nursing and our EMR, and we added the POS scale to our reassessments. When you administer any pain medication, you automatically get a 30-minute, if it's IV, and a 1-hour time frame on your administration on your EMR, and then you have the POS scale to reassess. And our focus was Dilaudid at first. That's where we focused on. This is a report that our quality analyst gets every morning, and she sends it out to each nurse manager to let them know who did not do their reassessments, because we want to make sure those nurses are going in there and getting their reassessments done. It also gives us an opportunity to see what dosages are being given and what patients and where, so we can look at it. So it gives us a lot of information for that past 24 hours on the Dilaudid. And this is Eleanor Odom, who started rounding, and she's going to talk to you about that. Let me ask you, how many of y'all are doing post-operative monitoring on all your patients for the first 24 hours? Okay, so when your patients come out of the OR, you're automatically monitoring them for that first 24 hours with O2 sats and CO2 monitoring? Anybody? Everybody?
Okay.
Okay.
Very good. Good morning. Well, we had been monitoring this for quite a while. However, in July of 2016, we took it further. We have a daily report that prints out that tells us all patients that had surgery and went through PACU the previous 24 hours. So what I started doing in that year was going out each day, taking a look and making sure those patients were having the proper monitoring done. And if there were any incidences where, for instance, they were given Narcan, I did deep dives on those particular patients. I spoke with nurses because I've taught, so I'm a proponent of real-time education. So if there's any misconception of, at what point should I have done this or that or document it differently, tell me now. So that's what I was doing. At that time, when I would send out my recap of those rounds each day, I disseminated it further up the ladder to the leadership so they would have an idea of how compliance was going on these particular patients. I also sent it to the nurse managers. I actually put nurses' names in it so that they could also speak with those nurses. And I gave them a lot of information that I would find. It became very valuable because people generally want to do the right thing. We just have to empower them with the education, the know-how, and the tools to do the right thing.
The managers like to call Eleanor the nice nuisance that comes by. But just to show you, this was a report when she first started, and it also helped that she CC'd the chief nursing officer in every one of them. This was, we put the warnings out when if a physician ordered over the recommended daily dosage of the Dilaudid, Demerol, and the morphine. And at this time when we put this out, we could not make it mandatory that they acknowledged it. We just showed it. So this was one of our first steps. And then in May, we added Narcan automatically to every IV opioid order. We had a standing order at the hospital that obviously you could go get it from the Omnicell and administer it if you needed to. But then we saw the nurses were like stopping and calling the doctor or asking if we can give it. So we decided to automatically have it. If you ordered it, it would be there for the nurses to immediately get it and administer it and not wait to call anybody. Then in June, we actually got the hard stop and where they would have to acknowledge if they ordered over the amount. And that's where it is where you have the hard stop and they have to acknowledge it. This is a sign that actually Eleanor found on vacation. Yes, she works on vacation. She found it in a hospital down in Florida. So we got the sign blown up huge and put in our ED entrance, our ambulance entrance, and our triage area to try to deter those patients who are coming in wanting their opioids to take home. And our ED physicians absolutely loved it. Of course, they wanted to add some more language to it, and I said no. And I don't believe you have this slide, but I'd be more than happy to talk about it or answer any questions about it later and share it with you. This is our data we collect on our Narcan rescues, and this is from 2016, and we broke it down per area, and we had 39 in 2016. In 2017, last year, we had 54. But what we did is we looked, because I was like, oh my gosh, we had more. But my CNO and CEO looked at it and was like, but we had less on the floors. And that's what we want. We want them not on our post-op surgical floors. And so, because that's what we were focusing on. If you look in the month of July, we had 7 in our ED. And our ED director was like, Sherry, what did I do? Which is exciting because I want you to ask me, what did you do? And what they did was they gave every patient the same thing. No matter if I came in with a kidney stone or the 80-year-old came in with a kidney stone with CHF, COPD, we all got allotted 1 milligram IV. But that was able for them to see when I broke it down. So then they had a group meeting among themselves and they included their mid-levels. So as you see, the rest of the year, they only had a few. And this is a detailed Narcan report that we show them. And I present it to each physician committee, and I also try to get it to that physician and to that unit so they know exactly what happened. It does take some time. Luckily, we're getting less and less Narcans, and so we only have, I think this year so far we've had 3 or 4, and that's it. But I look at the history of the patient, where it occurred, and then the outcome of the patient.
This is truly a labor of love for Sherry and I both, and we're kind of infectious, so when we're out and about, we're driving people to be as engaged with this process as we are. Almost a year to the day, we finally achieved 100% compliance in all the areas that we primarily do most of the monitoring when I'm out rounding, and it was a true celebration. And generally I'll take around some knickknacks, some meal cards to help encourage people to, I know we're at this point, but I don't want you to lose focus. I don't want you to drop the ball. Let's keep it going. Because I want them to feel proud of, their success. It's not my success, it's their success. They're at the bedside. They're the ones that are ensuring patient safety by actually doing this. I'm just monitoring for compliance and helping them along the way. So every day I still go out. Every day is not perfect, but I still celebrate them on those days that it is perfect. And I still do real-time education. I can tell you that whenever we are transitioning new staff on board, I go out and I'll round, and if I have a patient who's not being monitored properly, for instance, if I have a patient who should be on but I see they're off, I'm going to ask the question, why are they not on the monitor? Well, they may be ambulating in the hall with PT. Okay. If they don't know why the patient's off, generally I go more in depth. I'll even go to the room if they tell me the patient's refused. It's not that I don't believe it, But for me, have you discussed with the patient the value of this and why we do it? Well, I think the nurse last night did. Well, I take the next step. I go to the room. I speak with the patient. And generally, almost 100% of the time, they reapply it. They agree to have it back on because someone maybe have not gone into detail on why we do these things. When we get pushback from physicians that say, I don't want my patients on that, it's cumbersome, I need them up moving, we're not trying to keep them in the bed. It's on a nice rolling device. Let it go with them if that's okay. But we have a policy that says they will be monitored for the first 24 hours post-op. And so that's our expectation. But again, you have to relay that to people. They have to know what the expectations are, okay? So we truly celebrate 100% compliance on anything, okay? Click to the next one. Okay, this is our, it's called the Massimo Patient Safety Net. It is a device that patients, once they leave PACU, transfer to the bedside, to the rooms, it's immediately applied during the handoff. This device monitors SaO2, CO2, vital signs other than temp, and it's a triple threat is what I call it, because if the patient falls out of one of the preset parameters that have been approved through the medical staff, not only will it alarm at the bedside, we have a central monitor at the nurses station. It will alarm there. Also, the nurses have pagers that they assign at the beginning of their shift. That nurse gets a page that that particular patient's monitor is going off. It can't be silenced until the nurse goes to the bedside and addresses the issue at that time. Another nurse can go in the room and address the monitor, but we love it because we have actually caught patients that would have probably suffered had it not been in place, okay? So we are able to rapidly assess, rapidly intervene, and help our patients survive. Unfortunately, we know that some patients are more prone to opioids than others, so this particular device helps us no matter what the patient is, opiate naive, opiate tolerant, it's for all of them. We have it on 3 units. They are post-surgical units, and that's where the majority of our post-surgical patients go. And for the first 24 hours they wear it, and I take it a step further. If for some reason that patient is going to be on opioids extended, and we're giving them a nice sizable amount, some patients require more than others, we ask them to please keep them on it for an extended period of time. We want to make sure they're safe, and their safety comes first. But in the long run, we're ensuring patient safety, but we're also helping with ensure the safety of the hospital.
Our very first patient that came out of PACU that went to the floor and they put it on, we caught them and they had to go back to PACU immediately because they were over sedated by the time that they got to the floor. So what we did, we set our dose limits for our physicians. We added the POS scale for our nurses on administration. We put the sign up in the ER. We started making sure monitoring. We developed a policy for monitoring, which Eleanor talked about. We continue our daily rounds. We review all our patient safety events to see if opioids were administered. We do that with our RRTs and codes to see did they get an opioid recently prior to, what was the dosage, what's their comorbidities. We deep dive into each Narcan, and we present our Narcan reports to our medical staff. What is our future? We just we're implementing this week the stop bang in our outpatient surgery. We waited to this week because our chief anesthesiologist just got back from his honeymoon and I needed his support. So we started that so that way that if they don't have a diagnosis of sleep apnea, we know that they're at risk due to the stop bang, then we can go ahead and get respiratory involved in PACU, get their CPAP if they need one, and then continue the monitoring. I think that was our missing piece, is to continue monitoring these patients if they need to after that 24 hours. By labeling those patients as high risk, we'll put that in the header, so we know that the nurses will know they're high risk, and if they're still receiving IV opioids, then they'll need to be continued monitored closely. And then by putting our monitor, Massimo, in every post-surgical room so that the nurses will have that piece there that they can do it. Thank you for allowing us to talk to you. This is our contact information. Eleanor and I love this topic. Please feel free to email us, call us, and we would love to share anything with you. Thank you.
We appreciate Spring Hill sharing their experience with us. We also appreciate what Blue Cross is doing to try to help with this initiative statewide. And if I'm, oh, okay. I thought you were telling me you couldn't hear me.
Yeah, 5 minutes, Keith, okay?
All right, sounds good. I'm trying to figure out the smoke signals and hand signals. And, you know, if the building's on fire, y'all leave, and when you're gone, I'm going to follow you. So we'll get it all figured out. So thank y'all very much. Let me just recap very quickly a couple things that happened in the task force meeting we had last week. And if I were trying to give you an early indication, perhaps first steps that I might suggest for your institutions, because all of us may not be as far along as we heard Spring Hill's initiative here, and we may not be really down the path yet of really changing a lot of physician behavior in our individual institutions. I think what we learned in the meeting last week, and then we'll open it up to questions here, is probably we would all be well charged to go back to our facility and start working with our pharmaceutical department and with our medical staff to learn what are the prescribing practices in your organization. We think that probably is going to be specific to service lines. We don't think necessarily that you can expect what will be happening in your hem-onc area to perhaps be the same that you would find in your orthopedic or your general surgery or even your ER prescribing practices, just as we heard the example that was given by Dr. Weaver earlier regarding his practice versus not necessarily knowing what his peers might be doing either the shift prior or the shift after. And I suspect that's probably representative of most of our institutions. So I think we realized in that task force that most of us really don't know, nor have we looked at with substantial depth yet what our existing prescribing practices are. So it seems like the foundational point we should all take is figuring that out in our individual institution. Then engaging our medical staff, perhaps in a discussion. We used an example in that meeting where we were in some other quality measures years ago when we asked the physicians to look at their routine orders or their standing orders or whatever you want to call them in your organization. Clinical pathways might be a term you would use. When we asked the doctors to look at that, they had some things on that list they'd been doing for 20 years and really didn't even know why they were still on their order sheet. So I suspect we probably have some of those type prescribing practices that may exist. Perhaps my organization was the only one that has that in the state. The rest of you are far more advanced than that, I'm sure. But we thought that those might be two initial steps, that if all of us undertook those steps, we would be more informed in our future discussions. And with the support of what we were getting from the payer community here, all of this may help elevate that discussion to our physicians. I think the third thing we probably had to acknowledge is that for the most part, listening to our physicians, most of them have not necessarily been trained very effectively in terms of how to deal with this whole issue. Most of them learned what they learned by the work they did with a particular mentor perhaps in their program, but they didn't really sit around a table at times and talk about what do you think we should do, what are you doing, how might we be able to do this better. So I think we have a lot of opportunity in both our residency and medical school and training programs and in our own medical staff committees to elevate this discussion and learn from each other. So we look forward to being a part of that discussion. Again, ours is not about placing blame. It's not about pointing an accusatory finger to somebody and what they're doing. It's really about elevating the conversation to where we can improve performance. So I wanted to share that background and invite your participation and assistance going forward on that. So with all that being said, let me now stop and see if there are questions in the audience. We have one back here. Great. Thank you.
Yes,
Dr. Ennis.
thank you. I'd like to thank you for an excellent presentation and thank you, Mr. Granger, for your comments. As a physician who is now required to have CME in an area in which I, as you just alluded to, had no formal training whatsoever, I, as well as my other colleagues at Berkeley Baptist Health, have asked numerous questions as to how we can access opioid prescribing training for us, not only to meet the mark that we're required to have for our licensure going forward, but really to be the foundational information that many of us did not get in residency training or in medical schools. So if either Blue Cross Blue Shield or AQUAF has access to any programs that you could help us connect with to be able to provide that for our practitioners as we begin these discussions or as we move forward along this pathway, they'd be greatly appreciated. I did have one question in particular for Dr. Bright, and that was relative to the percentile scoring for physicians, and you alluded to the fact that we were compared to our cohorts, and so I wanted to know, is that a specialty-specific cohort, realizing, for example, that oncologists and orthopods may have very different opioid prescribing practices from what you would expect from a dermatologist, et cetera?
Okay. So yes, that's a great question. So currently we have what we consider generalists. So internists fall into that, obstetricians fall into that. We have a surgical peer group. We also have a dental peer group. We also have behavioral health, but that specifically kind of goes to the buprenorphine side of prescribing. But there are several different peer groups that are currently available via our system, but we are working to expand that even more. We, of course, certainly have a pain management peer group as well. And so we certainly don't want to compare a generalist or a primary care provider to a provider who is primary a dentist. I will say in every state, not just in the state of Alabama, there is a lot of overlap. So you have some providers that are via a taxonomy code, they are a primary care or family practitioner, but because they practice in a small area, they also are pain management. They're the specialist for their patients. So that's a tricky spot for us. What we generally speak to that, we want to speak to you in your practice. So even though you may be compared to the generalist, if I'm on the phone with a practitioner and you tell me 85% of what I do is pain management, then I'm going to speak to you like a pain management provider, but giving you parameters. So, okay, I see that your score is low. This is why your score is lower, because we have you in the generalist category. So let's look specifically at your patient loads. What can we do patient by patient? What can we look from a habit standpoint? I had a obstetrician that prescribed majority Percocet, but they would do 10 milligrams instead of 5. Well, if you do 10 milligrams every 4 to 6 versus 5 milligrams every 4 to 6, your morphine equivalent dosing is doubled. So just by that little change, that makes a huge difference in your morphine equivalent dosing. So those little things, even though we are comparing you to your peers, we have to take into consideration how we say you have to look at the whole patient. We have to look at the whole practitioner in the practice to see what are the actual prescribing habits there, and we try to adjust based off of that. So we do look at the number, but we also mainly focus on the patient alerts.
Okay, great, thank you. Back to the other question regarding training materials. Either any of our panelists, Dr. Reader?
I was going to say Axial certainly, and I will have my card available. We have pharmacists that are available to come out and provide education talks for practice offices, so we're happy to do that. I know we're also looking for kind of the CME credit and things like that. We don't currently have that in place, so if you're looking for credit as far as continuing education, that would be something separate outside of Axial, but we're more than happy to set up a time and do a conference call, come down to the office and walk through and talk through any questions or concerns that you may have, or present on pain management as a whole. We do have several pain educators on our staff as well.
I will just add to that answer, and we'll move on to the next question. At the association, I think probably we're starting to look more around some of the CDC components relative to that. And part of that is because we had a lengthy discussion here in the Birmingham Regional Council, and I think most of the hospitals wanted to find some commonality of a standard that they could perhaps stand behind, particularly if they were confronted with standing in front of their medical staff. So I think this example that you just gave, but also there's some stuff on the CDC website, I believe Margaret and Rosemary might could help get that. But that seems to be where we're kind of leaning right now with some of that early part. Okay. Early, let's say, I'm sorry, another question. All right, thank you, Margaret. Is it working? Try again. Now we can.
Okay, great. Great job on the presentation. It's something that we struggle with and we're trying to identify improvement efforts around trying to help our patients our prescription patterns, how we see patients who may be opioid addicted and good in the hospital. My question is really around the sign that you posted in the ED. Some of the improvement efforts that we've tried in the past within the emergency department was posting specific signage, not necessarily related to opioids, but to different things. And we've had surveyors in the past who tell us that you can't post signage like this because it could give the perception to the public that you're trying to deter them from coming in for the treatment, and it's an Tyler violation. I just wanted to ask you whether or not you've had any of that kind of experience or any pushback from surveyors or even from administrators and that stuff.
And if y'all will you repeat that question, because nobody up here could hear.
Okay.
So,
I'm going to do the best I can to narrow it down just a little bit. I'll probably make it shorter, but I guess the question was primarily, have we had any problem with surveyors and others taking certain of our actions to being perceived as being pushback for them coming into our facilities? Is that?
That's exactly right.
Okay.
In regards to the signage that was posted in the ED related to opioids or pain management safety,
Okay.
have you received any pushback from regulators or from administrators who may say that that sign could be perceived as a deterrent for entering the ED or an Tyler violation?
Okay.
We have not
I'll
received-
admit it's the first time I've heard it, so I look forward to other answers.
We have not received any pushback. We present this to administration before we present it to our ED committee. We also had a joint commission survey in November, and they did not find it in a violation at all.
As you probably noticed, Joint Commission surveyors vary a little bit. Some places get this kind of advice, some get that. Those are the same Joint Commission surveyors who 15 years ago made pain the additional vital sign, which got us to where we are now by saying you have a right to be in zero pain while you're here. So the problem is part of the solution. So.
Good. All right. Other questions? Someone back here? Yeah, as you are asking your questions, do please try to speak up so the whole room can hear. That would be helpful.
Thank you. I would like to ask a question to Sherry and Eleanor. First of all, you did a great job in the presentation. I appreciate that. Curious if you've thought about having guidelines that help to determine when the patient should be transitioned to oral medications in the hospital rather than remaining on the IV medicine.
Yes, we have. What I try to ask physicians and what our managers go to the physicians about is we take the stance that if they can tolerate PO, that they are switched to PO medication. So that's what we try to educate throughout, and so does Eleanor when she makes her rounds. We do not have it in our writing yet, because to get all physicians to agree on that right now, we would like to our next step. But we have a kind of underlying rule, and we ask the managers and the nurses to approach. Because if both are ordered, then they'll give them PO, and unless they're vomiting, or if they're going to have a big wound debridement or a dressing change that may cause a lot of pain, then they'll give the IV. But it's kind of our unwritten rule right now.
Good. Another question right here?
I'm here. I have two questions. First, for the Spring Hill group, on the hard stop computing how the total narcotic dosage, is that something that only physicians can see, or can the nurses see it in the EMR?
The nurses can see it as well.
Okay, great. And then for the young lady with Axial, and you talk about keeping up with the patients and the number of narcotic doses they're prescribed, and then you have all this data and information about procedures and a risk score. So in all of that, do you ever evaluate the effectiveness of whatever pain management the physicians are doing? And if so, how are you evaluating that?
So we don't personally evaluate it at Axial as far as the effectiveness. We evaluate outcomes in regards to whether or not their dosing has been titrated down overall for the provider. So at a patient level, we push that back to the provider. But as a provider, we specify with them that overall over a certain time frame that their morphine equivalent dosing has trended downward, their duration, the length of time that their patients are on an opioid has trended downward. So those types of things are what we actually.
What we're striving for here is to affect the appropriate dosing. There are plenty of patients who need a high level of opiate out there. There's some who don't. So we're just hoping about bringing this to the forefront. Physicians' prescribing habits, they'll think about, does the person really need that much or not? Do they need this many pills or not? But we realize there are people who need that.
So when you say they need that, how are you evaluating need other than just total dosing? And you can use the other word, outcomes, like physical functionality, sleeping well.
We're not evaluating it that way. We're going to be looking at it over the next year or two on overall health outcomes. So as we look at claims data coming in, do people have fewer hospitalizations, fewer other problems? We're going to evaluate it that way, but not on a day-to-day basis. We're still leaving that up to the physician to decide, is this an appropriate dose or not?
Thank you.
Okay. I'm going to have one more question, and then we'll kind of cut it out, and maybe they can be available during, okay, Carrie?
Just a real quick question. You talked about medical staff oversight for these kind of prescribing practices. Is it possible with hospitals having employed physicians and provider-based clinics to have access to this data as part of FPPE or OPPE?
Are you talking about is an employer, so that an employer employs a bunch of physicians, can the employer see that data? I'm not sure that answer. I know it's available to the individual physician.
And it's available to representatives of the physician. So but that's based off the physician giving them access. So the physician could give them, or the provider practitioner could give them access, but we don't necessarily give access to that. If that makes sense.
Yeah, I was trying to think as you asked that, Karen, about whether, I don't think it's embedded in our contracts. I'd have to read it very carefully, but I certainly would have no objection to asking a physician, since you're our employee and we're providing oversight for so many other components of certification, accreditation, and we're paying for your medical license and we're paying for this, that seems only appropriate that we perhaps be able to invite them to share that with us.
And it would be easy OPPE.
Yeah. Okay, I'm going to cut off the questions, but let me add just a little tidbit here at the end. Again, do most of you know where the addictive respondents would say their initial opioid usage came from? Most of their answers are, as it relates to a medical connection, is that it came from oral surgery or dentistry. So as we are working in this area, we certainly have lots of work to do. But again, I think that's why it's important that we figure out what is the prescribing nature of our practice is within our facilities, because we may uncover something that we didn't know. I certainly have always thought about that possibility, but I saw the data for the first time about a week ago, and it just reaffirmed what I guess I had suspected, but I really didn't know it. So again, I would encourage all of you to look, think. This is much bigger than just hospitals and doctors. It is a societal phenomenon that we're going to be dealing with. But ideas like the ones we've heard here today certainly give us tools in our armament to address that. So thank you all very much. We're running just a tad early, not much, but I know that many of you have been sitting a long time. So I'm going to give you a 5-minute break, even though there's not one in the agenda. So if you'll take 5 minutes and then come back promptly, we'll get started again.